So hello, I'd like to welcome all our viewers, everyone from around the state who's tuning into this OrthoVirginia Facebook Live event. We really appreciate you being with us, and we hope this is educational for you and you really get a lot out of this. So my name is Michael Wynn. I'm a joint replacement specialist with OrthoVirginia here in Richmond. Just a little bit about OrthoVirginia. OrthoVirginia is the largest multi-specialty orthopedic group in the state. We have offices in Metro Richmond, Northern Virginia, Lynchburg, Virginia Beach, and Blacksburg. So we really cover the whole state. If you'd like to learn more about us, you can go to www.orthovirginia.com to learn more about the services that we offer to our patients. So our topic today is rapid recovery after outpatient total joint replacement. We're really fortunate today to have a patient of mine, Vivica, with us. And she's a patient who underwent bilateral knee replacements at our outpatient center within the last year. And so I think it'll be especially useful to our viewers to hear her story, to hear about her experiences, and to have a firsthand account of what it's like to go through this process. And I really appreciate her being with us here today. I look forward to your questions at the end as well. I'm happy to answer whatever questions you have. So just a little bit about my background. I'm a total joint specialist here. I work out of our Johnston Willis office. I see patients not only here in Chesterfield County, but really all over the Metro Richmond area. We have a lot of patients that come from Mechanicsville, Hanover, Henrico, down to Farmville. So we see patients from a wide geographic area. I grew up in Tappahannock, Virginia, which is about an hour from here. I went to Duke University undergrad, was a varsity athlete there, studied pre-med, and then went on to the University of Virginia for medical school. I did my orthopedic surgery residency at the University of Cincinnati. And after that, I decided to pursue some additional training in areas that were interest of mine. And the main area was total joint replacements. I spent a year in Nashville, Tennessee at the Southern Joint Replacement Institute, where I learned from 3 excellent surgical mentors the nuances of joint replacement, both primary joint replacement of the hip and knee, revision joint replacement. I spent a year just immersed in that, learning a lot about that. I then spent a year in Perth, Australia, where I studied advanced sports medicine techniques, and that was a great experience as well. I had some great surgical mentors, really enjoyed being there. It was a great place to spend a year. I met my wife while I was there, so that was another added bonus. After that, in 2009, I returned here to Richmond. I've now been in practice for 13 years. My wife and I and our kids live here in Richmond. We live in historic Church Hill. We are the proud parents of 4 amazing boys, which is a huge blessing in our lives. So my practice, since I started 13 years ago, has grown a lot. I've been truly blessed in that. Patients have placed a lot of trust in me, and at this point, I perform 800 to 900 total joints a year. So far and away the most of any surgeon in Central Virginia. And what we're going to talk today about is moving the joint replacement surgery from the inpatient setting to the outpatient setting. And this year, I'll probably perform about 300 total joint surgeries in the outpatient setting, which again is more than anyone else in Central Virginia. My practice is focused primarily on hip and knee surgery. So I do primary hip and knee replacements, which is what most people have. So someone has arthritis and they have their joint replaced. I also see patients for revision hip surgery and revision knee surgery where there's been a problem with a pre-existing implant. I perform hip resurfacing, which is a great surgery for appropriate patients, and also partial knee replacements. So we really try to offer all services for joint replacement to our patients. So to get our topic started, I'd like to discuss a little bit about the underlying problem, why people have joint replacements to start with. And when we talk about joint replacement today, we're going to limit our discussion to the hip and knee. So hip and knee arthritis can be a debilitating condition. It can limit the ability of the patient to interact with family, to perform normal activities. What the basic problem with hip and knee arthritis is the loss of articular cartilage in the joint. So the cushioning cartilage goes away. You end up with essentially bone-to-bone contact, which results in inflammation, stiffness of the joint, and pain in the joint. When that occurs, it's significantly detrimental to quality of life. When we see patients come in, there are conservative treatments we can work on for this, such as cortisone injections of the joint, anti-inflammatories, Advil, Aleve, things of that nature, and also physical therapy. And all of these can be helpful, but usually in a short-term manner. Once you have loss of the articular cartilage and resultant joint inflammation and pain, typically the only long-term lasting solution for a patient is the surgical option. And that's what we're talking about today, which is joint replacement. So a little bit about the history of hip and knee replacement. The first hip replacement was done in the United States in 1969 at the Mayo Clinic. Dr. Coventry did that. It hasn't been that long ago. It's only 50 years since we started doing this procedure. Originally, when patients first had this procedure, they were in the hospital for sometimes 2 to 3 weeks. They were in bed for several days. So it was considered a major surgery with a long extended recovery. When I began practice in 2009, our patients at Johnston Willis almost everyone stayed 3 days. That was the standard of care. You had surgery on a Monday, most people went home on Thursday. As I went through practice over the last 13 years, I've seen that length of stay decrease from 3 nights down to 2 nights, down to 1 night, and now same-day discharge. And that's what we're talking about, is not only same-day discharge, but moving the surgery from an inpatient hospital setting to an ambulatory surgery center setting. So one of the questions that I would have if I were a patient or if I were a listener today is, that sounds great, but how is that possible? How do you replace someone's knee or replace someone's hip, and then they go home a couple hours later? This sounds crazy. And I admit that it does sound crazy at times. However, we've done it through really incremental improvements over the years in several ways. So surgical techniques, we'll go back to the first hip replacement. The first hip replacements were done through a 16 to 20 inch incision through the buttocks area. It's called a posterior approach. It's very invasive, and there was a lot of blood loss, high need for blood transfusion. Whereas today, I'm doing all of my hip replacements through an anterior approach, which is a muscle-sparing approach through the front. Don't have to cut any muscle, through a 4-inch incision with minimal blood loss. So over the years, we've improved our techniques. Anesthesia techniques have improved. Anesthesia is much better at managing patients' post-op nausea, vomiting, managing patients' pain afterwards, regional blocks prior to coming to the operating room to help control your pain afterwards. So all of those things have allowed us to mobilize patients earlier. We now use multimodal pain control. So we still use narcotic pain medication afterwards to help control pain, but we also have multiple other types of medications we're using to try to control pain through multiple different pathways. And a final issue I should mention is blood conservation. We have multiple medications now that really reduce our blood loss intraoperatively. When I first started, it was not uncommon for a patient to require a blood transfusion after having a joint replacement, whereas now that almost never happens. So we've really moved forward in several different arenas in order to be able to offer this type of service to our patients. And we're really excited that we've moved into this new era of joint replacement. So another thing that a patient may ask is, why would I want to have my joint replacement done as an outpatient? And there's several answers to that I've heard from my patients. One is to avoid hospitalization. There are some people that like being in the hospital. I think the majority of people don't want to be in the hospital. And so if you can avoid being in the hospital, especially over the last 2 years, when with the pandemic and everything else going on, it's been a very chaotic situation. And so a lot of patients want to avoid inpatient hospitalization. Being able to recover in your own home makes a big difference. And that's something we definitely hear from patients. Another advantage is it's efficient. So you come in to the surgery center, you have an appointed time, you get there, and immediately we begin getting you ready for surgery. You have your surgery. You immediately see physical therapy. Your family is with you within 30 to 60 minutes after surgery. You begin physical therapy, have something to eat, get your pain under control, and we try to get you home as soon as you're ready and safe. So it's much more efficient. There's other issues to consider, such as in the hospital, typically most patients have a Foley catheter in their bladder. You don't have that in the surgery center. You have a one-on-one therapist working with you within 1 to 2 hours of getting out from surgery. I think our anesthesia team that we're working with is really a great team, and they've really pushed the techniques as far as pain control, nausea control, preoperative blocks at the surgery center, which has made it a great experience for patients. And it's also very convenient. It's a very convenient way to recover. And I think that overall, our patient satisfaction at the surgery center has been great. So who would be a candidate to have their joint replacement done as an outpatient? Not everyone is a candidate, but who is a candidate? So the patients need to be in relatively good health. We have people all the time that we operate on. This morning, I did 2 hip replacements at our surgery center, and one of our patients was diabetic. She was well controlled. That's not a problem. We can manage that type of issue. But people with uncontrolled medical comorbidities, folks with severe cardiopulmonary disease, those patients are not going to be candidates for outpatient surgery. We typically want patients' body mass index under 40, so that's a measure of height to weight. So we want to keep that under 40. We want their medical comorbidities to be controlled. All of our patients have to be self-motivated to really get up and push themselves with physical therapy. So this type of surgery is for people that want to be active, they want to push themselves, they want to really get back to an active lifestyle more quickly. And generally, this is not a hard and fast rule, but most of our patients are probably under 70 that we're doing at our outpatient surgery center. So what are the experiences? I guess another thing I'd like to talk to you about is the experiences that I've seen, the feedback I've gotten from patients. Now, I've done hundreds of cases outpatient at this point. And so I want to share with you some of the feedback I've gotten from patients, which is our patient satisfaction scores are much higher overall at our ambulatory surgery center versus traditional hospitalization. I think that patients have had a good experience. I've had multiple patients who had one joint done as an inpatient at the hospital, and then their second joint done in an ambulatory outpatient setting. And the vast majority of those have remarked that they prefer the outpatient approach. We've noticed that there has been a lower overall less narcotic use post-op in our ambulatory surgery center, and I think that's due to early mobilization and excellent anesthesia techniques that we have. So we've noticed less narcotic use, which is great. We see an exponential growth in demand. So I have patients coming in now asking to have their joint replacement done at a surgery center or ambulatory setting versus going to the hospital. And that was really shocking to me. I didn't expect it to pick up that quickly and for people to really have such demand for it, but there's a huge demand for this at this point. And most of our patients that have had surgery in an outpatient setting are recommending it to their friends, family, loved ones, coworkers. They really are talking about it and they're very passionate about it. They feel very fortunate to have been through this experience. So where are we currently performing this? Currently performing it at the Boulders Ambulatory Surgery Center, which is located at the OrthoVirginia Boulders building near Chippenham Hospital. It's a really state-of-the-art facility. It's run by HCA, and we have great partners with HCA. It's a joint venture between HCA and OrthoVirginia, and we're really appreciative to our great partners at HCA. HCA, to me, has been a great partner, not only in Johnston Willis Hospital since I started in providing all the equipment and everything I needed to take great care of patients. They've also been a great partner in working together to offer the service to patients, and they are fully supporting it, and I appreciate the administration and everything they've done. A little bit about our staff over at Boulders. We have great staff. I think they're some of the best staff in the city, starting with our front desk folks, our pre-op nurses, our surgical techs, our circulating nurses. Our anesthesia team is really top notch. Our post-anesthesia nursing care. We have a great physical therapy team that is accustomed to working with outpatient joint replacement patients that do a great job of making sure the patients can do their activities, can pass physical therapy. They're safe. First and foremost, they're safe to go home, and training them on exercises to do once they get home. So, and the administration at Boulders has been great. They've been great to work with. They have obtained all the equipment we need to provide this service in an elite fashion, and I'm really thankful to them for doing that. So I think we have a great situation, a great place to perform this. So just quickly, what does a day of an outpatient? So if you're a patient, you're considering surgery, how does this look? What would you expect? So you would come, so if you were seeing me, you would come to my office, we would see you, evaluate you, and decide if you were a candidate for a hip or knee replacement. If you were, we would discuss the option of outpatient surgery, and if that's the route you decide to go, we would schedule surgery. You would then, in the weeks leading up to surgery, you would be called by the surgery center. You would actually go, in this case, to the Boulders Ambulatory Surgery Center. You would meet with the anesthesia team. You would meet with some of the team at Boulders. You would have preoperative labs, any appropriate preoperative test that you needed. So that would be done ahead of time. You would have some patient education. You then arrive the morning of surgery. Pretty much immediately you're brought back and the team begins getting you ready for surgery. Our great anesthesia team gets you set up, does some preoperative blocks to control your pain that are long-lasting blocks with anesthetic, get you back, we'll do your surgery in an efficient manner. Most of the time, the surgery takes a little less than an hour. Come out to the recovery area, wake up, get something to eat, get your pain controlled, and immediately you have a top-notch physical therapist waiting to work with you. Your family's with you at bedside. Then the therapist is educating you and your family or significant other, whoever you have as your care team you bring in. The therapist is working with all of you as a group, so you know what's going on, which is a real added advantage. So your family is not in the dark about what you're doing, and the family can see what you're doing. And then once you're ready, you're safe, your pain's controlled, you're able to eat and drink something, then we let you go home. And we have pain medicine we send you home with, multiple medications we send you home with. My staff follows up with patients next day by phone to see if they need anything, any changes of medications. And then they're back in the office 2 weeks later seeing me. So I think we have a great service that we're offering to patients. And I feel really grateful we're able to offer this. I'm super excited about the demand I've seen from patients in this in the Richmond area, and I'm just really excited to be able to offer this service to patients. I think at this point, we're going to have Vivica come and speak to you. And after that, we will try to answer any questions you may have. So I appreciate your time. Please, if you wouldn't mind telling them a little bit, it would be great. So Vivica had both of her knees replaced. I think it was May and December.
Correct.
And she was pretty limited before the surgery.
Yes, very.
And maybe if you could just talk to our guests a little bit about your experience with boulders and just your experience with knee replacement a little bit.
Sure. My experience with boulders was excellent, all the way from my pre-op visit. When I was getting my first knee replaced last May, I was very nervous about it. And the pre-op nurse did such a great job answering all my questions and helping me feel relieved about the decision I had made, because my knees really were impacting my everyday life. So the pre-op visit was really good. The anesthesiologist did meet with me, very nice team. And then the day of my surgery, it was amazing. I came in at 6:30 in the morning, reported in, and they took me back pretty quickly and got me ready for surgery. And next thing I knew, they were waking me up and telling me it was time to get out of bed. And the physical therapist did a great job with me. And I think I was home by probably 3 o'clock in the afternoon. It was amazing. The great thing I think about the outpatient surgery isn't just the experience, but the fact that you get to go home afterwards. Your family or caregiver can get you what you need when you need it. Icing was really a big soothing factor for me after surgery. So I was able to get icing done anytime I wanted it. We were able to get on a real schedule with my pain medication, and that allowed me to minimize any pain or discomfort I had. And quite honestly, after the first 5 days or so, it gets tremendously better. You're able to get up more on your own without assistance. And at that point, I started outpatient physical therapy, day 5 after both surgeries. And so getting out of the house was really a nice mental lift because you weren't stuck in the house all the time. And the PT group that I used, it wasn't OrthoVirginia. I think a lot of them are great around town. And I'd go 3 days a week, and I had my second knee done in December, and I'm already doing my own PT now. I don't go to physical therapy. I've been released from that.
You're an expert now.
I am.
You mentioned beforehand a little bit about being able to control your own pain.
Yes.
And so maybe just share with our listeners a little bit about how you felt that was helpful.
Okay, well, I was really nervous about the pain when I was contemplating getting my first knee replaced. And what our system is we set an alarm on my iPhone next to my bed. And so when it was time for my next pain medication, My daughter would come in and help me and take it. And so that way it never got out of control. One of my daughters was hospitalized a few years ago. And what I found is the nurses are so busy when they're taking care of you in the hospital that they don't stay on your schedule all the time. It's not that they don't want to, it's just they can't. But this way I got to control it, and I got to control the icing, and the icing is really, really smooth or soothing the first few days after your operation.
Sure.
So I found that very helpful. Also, the blocks that they put in me at the ambulatory center, I don't think I had any pain for the first 24 hours. Now, I wasn't up around all the time, obviously, but I didn't really have to worry about pain medication for that first 24 hours.
Our anesthesia team does a really great job over there. That's an important point. How about the physical therapist that saw you after your surgery in the recovery area? Did you feel like you got adequate instructions and
yeah, it was a woman. I'm sorry, I don't remember her name, but she had me up out of the bed, showed me how to use my walker, then actually had me go up and down a few steps because I have stairs in my home and my bedroom's upstairs. So I needed to be able to go upstairs. And she did a fabulous job showing me and demonstrating to me how to maneuver after my surgery.
And maybe just in general about knee replacement, if you could comment to our listeners about how the limitations you had before your surgery and now what your life is like and sort of how your recovery has been, how you've been able to get back to things.
So I think I'm relatively young for knee replacements. I've been struggling with arthritis for well over 5 years before I had my first knee done. Sometimes it got so bad I had to use crutches to walk across the room. I had gotten to where I wasn't able to walk a mile. So I have teenagers and young adult children, and we would go on a trip like Smithsonian, and I just have to sit in a chair while they went and look at the exhibits. So it was really necessary for me to have any quality of life that I should have at my age. And I like to golf and I like to do some outdoor activities, and I wasn't able to do that. Since my second knee, which was in early December, I have very little to no pain at all. I'm off all regular pain medications. And I was sharing that at spring break, my children and husband and I went to Disney, and I walked 18,000 steps in a day. And I couldn't believe it because I couldn't have done that before. And I keep telling my husband, I know he's tired of hearing it, that this is a miracle for me. Yeah. It really is. I can't believe that I can walk around without pain. And last week I played 9 holes of golf and walked it. Yep. And had no pain. And even that night, I wasn't bothered at all. So it's just amazing.
That's great. It's great to see. These are the types of stories that, as a surgeon, make me feel so fulfilled, is to be able to offer this type of service to patients and have them get back to the life that they want to live. Because not being able to walk and participate in normal activities plays a role in not only your comfort, but your ability to interact with family, to do things with friends, to do things with your kids. And so it's great to hear Vivica's story. Golf game's going okay?
Well, I have to work on that. But I will say one more thing about the anesthesiologist group. They took my feedback into consideration about everything. And when I went to have my second knee done, I talked to them about some of the after effects of nausea I had. And they really tweaked it where I had very little to no nausea after the second one. So I felt like they listened to me as well.
I think there's a lot of, in the ambulatory setting, a lot of individualized care because we have a smaller group of staff we're working with. And so we can really focus in on those fine details and try to streamline the patient experience as much as we can. And I'm happy they were able to do that with you. I was just talking with our anesthesiologist today, our head anesthesiologist, about doing that. And he's very engaged and wants to really constantly hone in and make this experience better and better for patients. And I think they really have over the last couple of years. It's a great overall experience.
Right. And the nurse that did my pre-op, she had her knee replaced several years ago. And I was very nervous about it. And she said, well, let me just say this. You're at this point, and I've never heard anybody tell me I should have waited. Right. And I would say that if you're already at that point where it's affected your life and your surgeon is open to replacing your joint, it's time. Yeah. And to put it off, all it does is interfere with your life.
Right. Yeah. It's not going to get better.
No, it doesn't.
Well, I really appreciate you coming and sharing with our viewers, because when I talk about it, um, it's one thing, but when they actually speak with someone who's been through it, not only once but twice,
Yes.
I think it really makes people feel more comfortable about the idea. And so I'm very appreciative of your time coming in and sharing this. And I'm just so happy that you're feeling so much better and you're
Yes.
walking around Disneyland and playing
I
golf
know, it's
and
great.
hanging out with your kids and doing the things you want to do and not using crutches.
I know, it's wonderful.
So at this point, maybe questions. So if we have any questions, I would be happy to try to answer that from, anything that you might have.
All right. Well, thank you so much, Dr. Nguyen, and thank you, Vivica, for sharing your story. We do have a bunch of questions coming in. So one of the first questions is, if you need knee and hip replacement in the same leg, which one do you do first and why? And how much recovery time do you need to wait between them?
That's actually a really good question. So we run into that with several of our patients. You typically do the hip first, and that's for several reasons. First of all, it's very difficult to do your knee physical therapy after surgery with flexion and extension of your knee if your hip is so stiff that it won't move. So from a PT standpoint, it's much better to correct the hip problem first and then to correct the knee problem. The other reason is that a lot of times hip arthritis can refer pain to the knee significantly. So we see some people who come in have severe hip arthritis and maybe moderate knee arthritis, and they may feel like the problem is just as much in the knee as the hip. However, if you correct the hip with the hip replacement, in many cases, their knee pain becomes much more tolerable. So you typically would start with the hip. As far as time between, I would say for hip and knee, I've done knee to knee as close together as like 6 to 8 weeks. So we've done those relatively close together. Knee to hip, I would say probably around 2 to 3 months, something like that would be the closest you would want to do it. Now, obviously, you could spread it out more if you wanted to, but I would say about 8 to 12 weeks to allow the hip time to recover, and then you could go for the knee if you really wanted to get them as close together as possible.
Thank you. Can I have an outpatient joint replacement if I live alone?
You can, yes, but we would ask that you make arrangements to have some type of care, at least in the initial post-op period. So we don't want to take anyone through joint replacement surgery and then send them home completely alone. You don't have to have 24/7 care, but we would want someone or a group of people who could be there to provide assistance to you if you were to need it, and just to watch out and make sure that you're safe at home. So we would want to send anyone home just completely alone, but we have a lot of people who do live alone, but work with family, friends, coworkers to have a team of people who can be available to them. So again, no one has to sleep at your house necessarily, but you need someone who you can easily call and someone who can assist you with some routine task in that initial post-op period. And most of our patients, we've been able to work with them to put together a team, a care team that can assist them in that post-op period.
Thank you. How do you know when it's time for knee replacement?
Well, there's several things. The key indication for knee replacement is pain and loss of function. So the X-rays matter. Typically, we want to see on X-ray that there's evidence of severe arthritis, and that lets us know that our diagnosis is correct. And I would say that the vast majority of people having, for instance, we'll talk about knee replacement, do have significant bone-on-bone changes, bone spurs or osteophytes in the knee. But a key question is, how much is it impacting your day-to-day life? As Vivica was saying, she was starting to use crutches to walk through the house, and she was not able to participate with her family and family trips and do the things she wanted to do. So there are different levels of tolerance. Some people really don't want to have surgery and they're willing to put up with a lot of dysfunction. Some people are more open to the idea of correcting the problem. But when I have patients that come in and say they come in with knee pain, I've seen them for a year and they've had some cortisone injections, and they ask me, well, how do I know it's time? I usually tell them it's time when you know that it's worth going through surgery in order to correct this problem. And I really like for patients to come to that conclusion on their own. I try not to push them that, oh, you need to do it now, because they don't. You can wait. It's not an emergency. However, each day that goes by is another day that you're living in pain, where you could have corrected the problem and moved on. So I usually ask the patients, how much is it affecting you? How much is it affecting your day-to-day life, the things you want to do? And then I discuss with them what their range of motion looks like. Are they losing their range of motion? What do their x-rays look like? And we come to a decision together.
Thank you. I'm not strong enough to be completely non-weight bearing. Can I still have an outpatient hip replacement even if I need to put weight on my leg?
Yes, you can, because for the vast majority of people, we allow weight bearing is tolerated on the leg after surgery. And that's actually a great question. And so for the vast majority of people, unless there's a problem during surgery or unless the bone quality is very weak, we allow patients to put full weight on their operative leg after hip replacement. Now, that doesn't mean if you're feeling great a week afterwards, you should go for a run. But it does mean that you are able to put weight on that leg. And so you do not need to bear all of your weight with your upper body. This is what allows people to get around and mobilize afterwards. This is what allows people to do the stairs relatively well, even 2 hours post-operatively, is that people are able to put weight on the leg. We're not doing anything strenuous, obviously, but for the vast majority of people, if you have a hip replacement, we're going to tell you can weight bear as you tolerate on that extremity. And so people who might not have as much upper body strength are still able to go through the surgery and recover just fine.
Thank you. You spoke about having blocks for knee replacement. Are the blocks also available for hip replacement?
Yes, which has been a great thing at our ambulatory center. I hadn't done this before in my career, but our anesthesia team has come up with a preoperative block regimen, injecting local anesthetic all through the area we're going to make the incision in, and numbing several of the nerves that innervate that area. And I've been really amazed at the amount of post-op pain control that's offered to patients. So for the knees, we're doing what's called an adductor canal block, which is helping to numb the front of the knee. And we also do what's called an IPAC block, numbing the back of the knee. And for the hips, we're going in around the lateral femoral cutaneous nerve and all around the front of the hip, since I'm doing anterior hip replacements primarily, and getting that area nice and numb. And that helps the patients a lot post-operatively mobilize with minimal pain, and helps decrease their use of narcotics as well.
Thank you. These questions relate to after a knee replacement. So after a knee replacement, is it possible to ski? Is it possible to kneel? And is it possible to get on the floor and get back up?
So ski, yes. We have a ton of patients who are both snow and water skiers. You can ski after knee replacement, no problem. Kneeling, after knee replacement, I would say there's a variety of feedback on kneeling. Most people don't love kneeling on hard surfaces after knee replacement. And so it's not that they can't do it, but it feels awkward to them. So I'd say most people don't do a lot of it, or if they do, they use knee pads or some type of softener for the surface. What was the last question, Margaret? It was skiing, kneeling, and what else?
Getting on the floor and getting back up.
Yes, so people can definitely do that. They can definitely get on and off the floor. So we have people at the gym I work out at. There's several patients who are my patients who've had knee replacements. I see them down on the mats doing ab workout. They get back up and ride the bike. So you can certainly get on and off the floor after knee replacement.
Thank you. How long after a hip or knee replacement can I drive?
So again, that's patient dependent. I would say that some of it depends on whether it's your right or left side that's being operated on. Okay. So most people drive primarily with their right leg or foot. And so there's probably a little bit longer. Typically I tell patients, I say 4 weeks. However, I tell them if they're moving around, they're not taking narcotic pain medication, they feel comfortable, it can certainly be shorter than that. And this is not a one size fits all rule, because if we have a patient that is coming along more slowly and not feeling comfortable at 4 weeks, we certainly wouldn't want that patient driving. If we have a patient that's one of our total hip patients that's walking with no walker, no crutches, nothing, just walking around the park 6 days after surgery and not taking any narcotics, then obviously that patient could drive. So it really depends on the patient. I would say for most patients, it's about 2 or 3 weeks, somewhere in that ballpark.
Thank you. How long does the replacement joint last?
It's another great question. So one of the things as healthcare providers and the industry that supports us creating these implants, one of the challenges has been to make these implants last longer and longer. As you heard when Vivica was talking to you, she's a little younger than most knee replacement patients. And I would say that the average age of our joint replacement patients over the last 10 to 15 years in the United States has gone down. So we see a lot of patients now having joint replacements for significant arthritis in their 50s, some people even in their 40s. We're hoping with the knees and the hips that they last at least 20 years now. I think the plastics that we're using in those are better and better. And there's been a lot of advances made in the last 10 years in that arena. I'm hoping for the hips that it's 30 years or more with the plastic wear rates we're seeing. And we don't know. The bottom line is the newer technology, we have lab data, but we actually have to put it in patients and watch them over time. But the early results, if you look at 10 to 15 year data on the total hips and total knees we're currently using, it's excellent. Very minimal wear rates, very low risk of failure. So we're hoping it's going to be decades and decades.
Thank you. How long after replacement is it safe to consider a long-haul airline flight?
Another great question. I would say, so a long-haul flight, I would probably say 6 weeks. We know the risk of blood clot or clotting, which is one of the risk factors when going through joint replacement, is there for elevated for somewhere between 3 to 5 weeks after surgery. If a patient did have to fly in that period, I would encourage them to take their anticoagulants. We put everyone on some type of anticoagulant, usually for 3 or 4 weeks after surgery. So they would take their medication, and I would encourage them to get up and move around, on a relatively frequent basis. I do have patients that do fly within the first month, but if they were going on a long haul flight, I would probably say at least 6 weeks.
Thank you. What is the average recovery time for knee replacement and for hip replacement?
So that question depends on what you mean by recovery. And what most people mean by recovery is back to most day-to-day activities. So they can go back to an office-based job, they can go out to dinner with their friends, do things like that. For young people with hip replacements, a lot of times they are back 2 to 4 weeks doing most things they want to do. If I were having a hip replacement, I would hope to be back in the office in 2 to 3 weeks. Knee replacement, probably around the 3 or 4 week mark. Most people are getting around and doing things. They're sore. There's no question about that. They're sore. And it does take a couple months to really get going. But I would say getting back to an office-based setting for hips, 2 to 4 weeks, knees, maybe more like 4 to 6, something like that, being pretty comfortable. But again, we're not, even from the first day, we want people up and walking and doing things. We want them trying to push themselves and do more and more. So no one's just lying in bed. It's just a matter of what people are referring to when they say recovery. Now, if we were to say when are the tissues after joint replacement completely healed, it takes a full year to completely heal, but the majority is in the first couple months. After that, it's a slow recovery as everything matures.
Thank you. How do you close the wound after a replacement, and why do you use that?
Okay, so these are all great questions, because when I was in residency, what we did was we stapled everything. So we put some sutures, we closed the deep capsule of the joint, and we put some sutures underneath the skin that more or less approximated the skin. And then we had a stapler and went boom, 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 boom. It was very quick. The problem with that is that it leaves orbital scarring, and the wounds tend to drain, which can put patients at risk for infection. So what I've done really since I started practice is we do a skin closure with dissolvable sutures underneath the skin. And then we use a skin glue over the top. Dermabond is one of the more popular name brands. There's several different brands now. The one we use now actually has a tape where the glue sits within a tape. And that does several things. First of all, it almost completely eliminates drainage from the wound. So our dressings very rarely have even a drop of blood on them. It significantly, in my opinion, reduces the risk of infection because there's nothing getting in and out of that wound. And the last thing, and this is important to patients, from a cosmetic standpoint, it leaves a very nice scar. So the scar at first is going to be more of a red scar. It's going to be a little bit broader because you're healing, but at a year out, most people are very happy with the way their scar looks, be it on the knee or hip. So we're not using staples. We're putting all the sutures underneath the skin with a glue over the top and just one small dressing over that.
Thank you. Do you still have to take blood thinner after surgery?
We place patients on an anticoagulant or blood thinner for the first 4 weeks after surgery. And the main ones that we use in my practice is either aspirin twice a day or a medication called Xarelto. So we've gone away from doing the injections and things like that. So almost everyone gets a medication by mouth, and based on a risk assessment, we either stratify people to an aspirin protocol or Xarelto protocol after their surgery for 4 weeks.
Thank you. Can you describe the rehabilitation process a bit more for a total knee replacement, and how long before you can walk upstairs?
Well, we're going to have you going upstairs at the surgery center. So you're going to do stairs the day of surgery, within a couple hours of surgery. That's one of our criteria for discharge. Now, obviously, you're not going to want to climb 10 flights of stairs when you get home, but you should be able, before leaving the surgery center, to do stairs. Now, as far as what the rehabilitation looks like, we're focusing on two main things with the knee. The first is range of motion. So we want to get people able to extend the knee fully and to flex the knee up to a reasonable range of motion. So we want to establish that mobility of the knee. The other thing we want to do is work on strengthening of the knee. So your quadricep is going to be weak after surgery. And so a lot of the activities are focused on stabilizing, strengthening that quadricep. And once we gain the mobility and the strength, then we work on gait normalization. So activities, normalizing your gait and moving from there into just everyday activities. How do I feel, when I go to squat down, how do I get back up? All of that stuff. But in the first several weeks, what we're really focusing on is getting that knee moving, the mobility, and then strengthening the knee, getting the muscles strong again to support the knee.
Thank you. Does rigorous exercise after a hip replacement, like road biking or hiking, increase the wear of the new joint and shorten the life of the joint?
So joint replacements, I do think there's good data that significant strenuous activity can wear the joint more. So we know that, for instance, historically with younger patients, we would see more wear than with older patients because 40-year-olds tend to be more active than 75-year-olds. I think, as I mentioned, we're in the hip, for instance, now we're using a lot of ceramic balls with vitamin E infused plastic, and that has excellent wear rates, great wear rates. However, I would still tell patients, I see patients that have all types of demands and want to be active. I see my patient population for hips and knees tends to be pretty young and very active. So I'm dealing with a lot of people who are in their early 50s. They want to be active. They want to bike. They want to hike. They want to go out and play certain sports. And we talk about that. Would I recommend playing tackle football after joint replacement? No, I wouldn't. Would I recommend marathon running? Probably not. But we do have patients that run. We have patients that participate in what I would consider moderate athletics, which would be even singles, tennis, skiing, as we mentioned earlier. Have a lot of people who are hikers, a lot of people who are cyclists. So I don't see any problem with cycling. I don't see any problem with hiking. I think the thing that we want to avoid is probably repetitive, high impact activities with the hip. So that's, or the knee. And so those are the things I would tell people. But most of our patients who are going through this want to get back to what I would consider moderate activities that I spoke about earlier. So we have lots of people that are active hikers, active cyclists, and even people that jog with these replacements.
All right, thank you so much, Dr. Nguyen. That is all that we have time for now. If we did not get a chance to answer your question, we will answer it in the comments later. Dr. Nguyen, would you like to close?
No, I would just like to thank all of you for tuning in. I really appreciate personally this opportunity to reach out to you and talk a little bit about hip and knee replacement surgery and then how we've moved that to the outpatient setting. Um, I do think this is a surgery that really changes people's lives, and being able to offer it in a convenient way now to folks outpatient has really been a paradigm shift. And I think we're going to see a growth in that going forward. So if you have further questions, please feel free to reach out. Myself or my colleagues here at OrthoVirginia are happy to help answer any questions or guide you through this process. Joint replacement, arthritic pain of the joints can be very scary, and it's something that really robs people of their life. So we want to be there and help walk you through the options to get your life back to the quality that you wanted. So thank you. We appreciate your time.